This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We're brought to you by
Butterfly Network,
Butterfly
as
Network.
always. All right, I'm going to let you in on something that's completely changed the way that I practice. I've been using butterfly probes for years. It's a portable ultrasound that you can use with your tablet or smartphone, and I can start scanning at the bedside in seconds. If you use the older versions, or even if you're new to the handheld ultrasound, let me tell you why the IQ3 is a game changer and really impressive. First off, having an ultrasound in your pocket is truly game-changing, whether it's for vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. It, excuse me, it has biplane imaging, which lets me see both short axis and long axis in the same view, which is really helpful in a lot of procedural guidance, as well as a great tool for learners. The new needle out of plane preset even lets me see the tip of the needle sooner. So when seeing it sooner makes a real difference, and precision matters. Ooh, having a hard time talking
Here
today.
we go. You need not enough matzo
chips
chips right here. Not enough matzo chips.
My lips aren't working. And the image quality, the IQ3 holds up against some of the high-end ultrasounds that I've used. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, we're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com using the code Brian25.
Here's the matzo chips.
Yeah,
we'll have to give some.
I need something.
Zane as
have
well.
Have you tried the matzo chips?
I love the matzo chips.
Oh man,
it's too expensive, but I absolutely love
them. I know. And we
how much are they?
I think it's like $13 for this.
Jeez! Shout out to Masa though. They can sell it,
but they usually do a bunch of deals where they do like you buy like 5, you get 3 free or whatever. It ends up being like $7.50 a bag, which is
Well, a friend of the show is joining us all the way from, let's say, Morocco, Japan, all across the globe. Pittsburgh nowadays. You guys remember anesthesiologist and social media guru, Dr. Zain Hassan. And Billy kind of, he left.
He's sitting right here. He'll be back.
Okay.
He's
joining us from your new studio, I assume, and in Pittsburgh, PA, man. Thanks so much for joining us.
Hey, happy to be on. I always love the opportunity to get on this podcast.
So we're going to talk about AI today to start with. I do want to share something. So ChatGPT is obviously a big AI platform. So do you know, if you put in who is the funniest anesthesiologist on the internet, on social media, do you know whose name comes up? That guy right there.
Is it really?
His comes up first. Yeah.
Hold on. Let me try. Should I try it out?
Do it.
Oh, that is
Hey, Siri, who's the funniest anesthesiologist on social media?
So your name comes up with like Will Flannery and
Magnolia Prince and Dr. Glaucom.
Yeah, that's Will Flannery. Yeah. So,
but he comes up too. Oh yeah, Dr. Hassan.
Yep, there you go.
There's the first name is Dr. Hassan. Right
there
here.
We go.
Video.
That's awesome. That's cool. You made my day, Brian.
Good. Anyway, we've Zain, you and I have spent a little time together chatting. We did some content together, and then obviously you've been on the show before. So, Zain really spends a lot of time talking about hot topics. Like he comes on, and I see you on social media all the time. Hot topics. And so I think today we're just going to bounce around some hot topics. I think the first thing we want to start with is AI. And so you've got an interesting perspective on AI to start with, and then I'll kind of share what I can without getting myself in too much trouble about what we're doing with AI in the companies I work with.
Yeah, so it's actually kind of an interesting topic, Brian. I've been researching it a lot because I'm kind of like a tech nerd. But AI has been, and I think will be, a major part of healthcare probably within the next 18 months. Now, I just put out a video, I think a couple days ago, where Elon Musk basically said, in a response, he retweeted somebody who posted about robotic surgery, and he said within 3 years, robots will be doing surgery, and within 5, they will be doing surgery better than the best surgeons. And obviously, his timelines are usually off. And I don't personally think so. AI is kind of two different in medicine. I think it's going to be applied 2 different ways. I think one will be software, and that has already started rolling out. And I don't know if I've seen a lot of medical creators kind of pushing these AI apps that essentially allow you to go into a patient room, talk to them, and it scribes it for you. I personally thought it was all like BS, and people were just trying to make a quick buck. And then when I came to UPMC, they've actually been using it, and the surgeons who are notoriously terrible at documenting notes, documenting whatever they're doing, what their plans are, blah blah blah. UPMC, I don't know which AI app they partnered with, but essentially they are bringing that app into the examining room when they meet their patient for the first time, and they have a full-on conversation with the patient about, let's say, a gallbladder surgery. They talked about, hey, what are your symptoms? What are we going to do? What's your recovery? And then they'll talk about, here and there kind of stuff, like the football team, the Steelers, or the weather or whatnot. And then they go back to after they see the patient, they go back to their app or their computer, and they say, hey, make me a soap note. And the AI will actually take the entire audio of what you talk to your patient about, take out all the nonsense. So the weather, the car ride, whatever else you're talking about. And they will create a succinct, descriptive soap note essentially for the surgeon. And they love it. I mean, it has absolutely, even to the point where they just describe the physical exam. They're like, oh, your belly's not tender, or your left shoulder has dysfunction, or your right, whatever muscle is strained. It will put that into the note as if the surgeon,
in H&P format.
Exactly, as if the surgeon's doing the actual H&P and physical. They'll say, regular rate and rhythm for heart, clear to CTA bilateral for lungs, whatever. It will integrate, and it saves so much time. That I am actually a believer on the software side. I think that's going to probably kick in 18 months. It will change the pace of how we see patients, how we talk to patients, how we document, which, Brian, is probably 60% of our day is documenting nonsense, and maybe 30% is actually taking care of patients, and 10% of the other stuff, right? And so I think that'll revolutionize that. And I don't think medical students and doctors kind of appreciate how it's going to change within the next 18 months. And then on the other side is the robotic aspect of it. There was recent news that there's a Medtronic robot. I think it's called Hugo, which I wasn't even aware that Medtronic had a robot, but they made it fully autonomous essentially. And it has completed successfully 136 out of 138 surgeries, ranging from everything from gallbladders to prostates to intestine surgery. And it's done it remarkably well. But it's had 2 mess ups. So 2 out of 138 is a pretty high percentage.
Oh yeah, way too high for it to be accepted, for sure.
Yeah. So
what about? Yeah, go ahead, Zane.
Well, I was gonna say I don't think that I think that is years away. I think robots, even the intuitive surgical robot, fantastic robot, but it doesn't have the ability to. You need a third person right now to move the camera around to see inside the body, and so I think that the robotic technology is not there. They show those androids like Tesla or Northrop Grumman or whatever that company is out in Boston. They'll show the robots, but they don't have the fine motor skills. So I think that is years and years away. But the software side of it, I think 18 months, it's going to change medicine.
What about the privacy side of it? So as a patient, right? So if you're coming in, do you tell the patient we're using AI technology? Or is it basically like just an aid, because you never really, like, if you use the recorder, you didn't tell the patient you used the recorder and you're recording notes, right? What level of privacy is there for the patient with this AI technology, and specifically UPMC?
Yeah.
That's interesting. So I'm not actually present when they do this kind of stuff. I'm just hearing the secondhand from the surgeon. So I'm not sure what the protocols they have. I imagine they have something in the consent that says, hey, you're going to have recorded essentially, or this is a test or whatever it is. So I don't know I'm sure it's HIPAA compliant, because these guys don't want to get sued no matter what. So I'm sure they go through all the legal rigmarole to make sure it's all good. But I don't know the exact specifics as to what type of guardrails they have for HIPAA compliant data, which I'm just guessing they're probably encoding it somehow, so you can't just click on a document and see what somebody's history and physical is or whatnot, or something.
We played with that a little bit with MedQuil.
We did.
Powered by Surgeon.
Powered by Surgeon.
Yeah, we played with that with one of the apps. Surgeon is a company. Well, Surgery Unified is the name of the company. Surgeon's the app that we partnered with, but they purchased one of these AI software basically for notes, and we went in and did a couple. It was pretty good. It even to the point where it's like, here's your CPT code, here's your ASA code, here's the plan, here's the amount of time you spent. Like it's pretty powerful. I agree 100% with the AI software. I think the big issue, like you said, is going to be how do we ensure that we're not getting like Skynet, right? Like that's my concern. And so if you look at the data, and I talked to Joe about this too, Joe Rodriguez from the Anesthesia Deconstructed podcast. If you look at radiology in particular, you've got AI has a certain percentage, 90 whatever percent ability to find findings on the radiology scans. Humans, radiologists, have a certain percentage, and they're pretty close. But if you put them together, they're synergistic. And so if you use AI to aid radiologists reading scans, their reading accuracy goes like way up. I mean, and they're good anyway, but it goes way up even for them. So I wonder if there's some way, even with the robots, where you can have a robot, like you said, like let's say they're doing a gallbladder, you still got to have somebody put the trocars in, move the trocars, change the trocars. I wonder if there's any way we can get the robots to do that part while you've still got a surgeon in the corner of the room actually doing the surgery in the robot. I don't know. I mean, I think it'll be crazy, but.
So an interesting point on the radiology. My brother-in-law is a radiologist, and they've had this for years now, where essentially the AI scans the CT scan or the X-ray ahead of time and just tells them that, hey, this is off, this is off, this is off, this is what I think it is, this is what I think it is, and the radiologists essentially confirm or change it. And so that's sped up their ability to kind of triage what's important, what's not important, and helped probably, I don't know if anybody's done any studies, but I imagine it probably helped with the overall results or efficacy or hospital stays or whatever impact of the healthcare system. For the robot part, I think you're 100% right. I think a lot of the monotonous, boring stuff, even just suturing or closing up wounds or whatever it is, the robots could do that, and that's not life-threatening, even if it's skin sutures or whatnot. But the intrinsic, like the micro movements, I don't know if they'll be able to do that anytime soon. But Brian, have you been? There's this new device called the Monarch or something along that line. It's it's essentially, you know how they do e-buses and broncs for thoracic surgery when they need to get a lymph node biopsy. And so, but for everybody listening, essentially, if you have lung cancer in like a random part of your body, let's say like super low down, like 10 years ago, you have to open your chest, and then they have to like take a biopsy of that lymph node to figure out what kind of cancer you have, to figure out what kind of chemotherapy you needed, blah, blah, blah. Then like in the last, I don't know, 10 years, maybe they developed this endobronchial approach where they just go through your trachea into your lungs and then make their way down to wherever that is and poke a tiny needle and just take biopsies of the lymph node. Now they have, but they couldn't reach, all the way down. Like they couldn't get, if you had cancer like all the way in the corner back of your like chest, the scopes were too big to make it all the way down there. Now they have this technology called the Monarch, which essentially, and there's another, Intuitive has one, and Johnson & Johnson has one. UPMC uses the Johnson & Johnson. Cedars-Sinai used to use the Intuitive version of it. But essentially, you put a giant ET tube in. I think you put like an 8.5.
8.5 or 9,
9, and then you cut it in half, and then you take this like robot and you just fix it onto the ET tube. When it has its own little bronchoscope that's super tiny, and they super fix the CT scan, or I don't know if it's CT scan or MRI, but they super fix that onto the screen itself, and the robot can essentially, as you push,
finds it.
So it directs you. It's like Apple Maps or Google Maps inside and tells you go right, left, down, up, and you can get down to where. So it's getting there. Well, my point is that technology is getting there. I think within a few years it'll be able to do the whole thing, autonomously, I imagine. But it'll get there, and that is going to be fascinating for that. But also for, if you think about, coronary artery disease, like the hardest thing that kills everybody. If they could figure out some way to do it autonomously, where the little J wires or whatever that is gets to the right point, exactly the right point to maximally dilate flow or whatever it is, as opposed to what we do now, Vahid, is essentially we use a C-arm or whatever, some X-ray fluoroscopy to figure out
pictures, basically.
And guess, right? They don't have like real time, like, data or whatever to over super fix it. So this will be very interesting to see how it changes the precision of medicine, for sure, like you were talking about radiologists, but also at some point I think they'll do it autonomously, and they'll just watch and make sure it's doing it the right way.
Well, I think part of AI is and I'm an infant at this, right? But so there's this whole idea of machine learning. So if you have 100,000 scans of whatever, a chest, the AI can only use those 100,000 scans to learn. But over 10 years, you might have, 100 million scans, and those 100 million scans allow it to learn just like a kid, right? If a kid is learning Spanish, if they only know 10 words, it's much harder for them. But once they get to learning 1,000 words, then they know how to actually speak Spanish. So that's part of it with the AI and the machine learning. The other thing is, so I think about this in terms of anesthesia. And so do you remember Sedasis? Do you remember that system that they came out with? I don't know, it's probably 2012, right? So Sedasis was a system where they're only using it for colonoscopies, but basically the patient had one IV that gave the propofol and one IV that measured the propofol levels in the blood. And so the problem was that it was not very effective. So a lot of patients were waking up and a lot of patients were getting over sedated. I wonder if AI can help us with that. I mean, you know, because they were just doing it by measurements of the blood. I wonder if AI can figure out a better way to do it. I don't know.
This is why I think AI for most professions, right, is not a replacement. It's an aid to help us do our jobs better, more efficiently. So you can focus as a surgeon on things that you can focus on to do better. And then, hey, here's a tool to help you. I mean, as a creator, I mean, Zain, you're big into social media. You're big into creating. I mean, it is not a replacement for photography, videography, production. Right. It's an aid, so I can focus on the most important things of the job. And this is, I think, if you're a patient, I think it's a little harder to adapt in this realm. But if you're a physician, this is very exciting because it helps you aid your job. Now, for patient-wise, it's really exciting that you can go in and get a piece of cancer out, you know, and have a probe do it instead of, hey, we're going to do a biopsy and cut you open and do all that stuff. But I think it's, you know, for patients, it can be for the older population, like we've talked about, it can be a little scary to have these things.
So I think AI is probably going to replace some jobs. Do I think it's going to replace physicians? No. But I was just on a call with an AI specialist who said it may replace primary care physicians because he's got data right now that shows that shows that, and it wasn't just physicians, it was nurse practitioners and PAs as well, but that AI is better at diagnosis and determining treatment than most primary care clinicians. So it may at some point do that. The other thing we brought up, and I love this because it gives me the opportunity to just crush on the insurance companies. So the insurance companies are now using AI. This is what this guy said. He said, you know, guess what? You're behind in billing already because the insurance companies are using AI bots. They're using AI algorithm, all kinds of stuff, AI to try to cut down on the number of claims they have to pay. So, and you can't even hardly tell anymore.
So you got a bot calling you, and then you got a bot making the decisions for you.
Correct. So there's even some rumors, and I have no proof, that the peer-to-peers are now being done by AI bots.
So I think at some point the insurance companies will use bots specifically. And it will actually, like you said, it will aid their peer-to-peer reviews and essentially allow them to say, hey, this is probably 80% chance this is a denial, 80% chance we're not going to be able to win this if they sue us or whatever, risk stratification. But what was the point you made right before that, Brian? I wanted to comment on it, but I forgot exactly what you're talking about right before the primary care physicians.
Primary care.
I'm of a different opinion, Brian. I think that it'll be a boon for physicians in our generation. I think it'll take away a lot of it will give a lot more time back to the physicians. And I think the advent of PAs, nurse practitioners, those kind of things was to allow a lot of the mid-level work, whatever it was, seeing the patient, diagnosing, or even just listening, or those kind of things, that because the physician can only see so many patients, so I think the dynamics will shift to the point. I don't think it'll be top down because
you think it'll be bottom up.
I think it'll be bottom up. You'll need supervision, whether it's surgeons, even primary care. I for sure think that right now, ChatGPT or whatever else could probably outdiagnose, the majority of physicians in the country. I don't think it's just primary care. I think you spit in, whatever vitals that we see in the OR, and you ask ChatGPT, hey, is this a thyroid storm? I think it could tell you by percentage-wise, whether or not it was. Now, can it do it and somebody act on it in the same amount of time? I don't think that little even though it can figure out what's going on, I don't think it'll be able to intervene in an emergent situation, whether it's pushing medications or intubations or doing whatever it is. So I think our specialty, emergent specialties, procedure specialties are probably safe in our generation. I think the next generation, it's going to be a toss-up, but our generation, that'll probably be safe. But I think, you know, ERs, primary care physicians, even like radiology, anything that's protocol based, you know, when you have like a script or the funny thing is the scripts and the protocols are usually deciphered or made by the insurance companies that, hey, if you want to diagnose whatever it is, back pain, you need, or if you want to have back surgery, you got back injections, you have to rehab, you have to do this, that, and the other. So those protocols are actually set up by the insurance companies because that's how they reimburse you, to make sure you did all the stuff before, you know, paying for the big back surgery. I think any field that is protocol driven, pathology, radiology, primary care, they're in trouble in the next 10, 15 years. I think a lot of people will turn to these alternatives because they just don't have time to see a physician, you know. And I think the primary care model will switch to more of a concierge type of model, that, hey, those patients that want the human interaction, they want a doctor to touch them, feel them, you know,
listen to them.
Yeah, you got to pay for it. And the other ones that, you know, it'll be like a regulatory thing. I think once the government says, hey, you can go to, you know, Google Health, or you can go to a primary care physician, you can get your blood pressure medication filled either way. That'll be a tough hill to climb for a lot of medical specialties out there.
It's funny you say that. So this guy we were talking to, so he helps run a whole health system in AI on the East Coast, but we were talking specifically about anesthesia. But I did ask the question. So what he said is the key right now, so it's not just the diagnosis. So they now have some integration of AI where the patient can call and say, hey, I'm having these symptoms, I'm sick, blah, blah, blah. The AI bot can listen, can diagnose, can prescribe a treatment plan, can call a consultative specialist, can call the pharmacy with whatever medication, and can call the ER or urgent care, whatever, if they're sending them somewhere else to actually be seen, and can actually get vital signs via the whatever screen, right? Like there's like some system that's set up where they can get vital signs for the screen. So it's like, it's crazy that, so I totally agree. Primary care, all these protocolized things are going to be, I think they're going to go away, not go away necessarily, but you know, there's going to be, you know, one physician managing, I don't know, 30 AI bots or something like that. What I did ask him though, is how do we do this in anesthesia? Right. And so what he said, two things he said, well, three, if you count sort of operational stuff, but actually clinical and anesthesia. One, preoperative testing protocols. So you got that protocol in place. This is what the patient needs. These are the results. Here's their risk stratification based on those results. And that gets sent directly to your EMR so that you know, oh, okay, well, this guy needs cardiac clearance. And then again, he said the same thing. Cardiac clearance can then be written for, sent to the cardiac clearance bot, and the cardiac clearance bot can then give cardiac clearance, and it can go back into the medical record. Like you said, predicting what's happening with like vital signs. So if you could, you know, let's say you've got an EMR and you've got an AI sort of system connected to it, you can get, you know, real-time predictions of what's going to happen next. So like you see a trend that we may not see in anesthesia, but this bot has seen 100,000 of these cases and says, hey, you better give ephedrine before the pressure drops any lower or the patient's at risk. And then the third thing was OR optimization, right? So you can plug in all the data from an OR and say, okay, well, you know, you shouldn't give this guy a swing room, or you should give this one a swing room or whatever. So, I mean, I think it's going to be crazy over the next, I'm guessing 10 years. I think Musk is a little bit too aggressive in his timeline, but
OR optimization should have happened like a year ago. I mean,
it happened 30 years ago by hand.
But now it should happen. I mean, it's not, in my opinion, OR optimization is more of like a popularity contest. You know, like I like surgeon A because he's better looking or he's nicer or whatever it is. So I'm going to give him the swing room because and you've seen it, Brian. You'd only have to work with, you know, a surgeon maybe 3 or 5 times before you can tell, hey, this guy is, when he says this will be an hour and a half, it's an hour and a half. And if he says 30 more minutes, it's going to be 2 more hours. It's not hard to figure. And then, you know, why are you giving a swing room to the slowest surgeon? Oh, because he's been around for 40 years or whatever. You know, so I think OR optimization is the lowest hanging fruit that would change healthcare and let us get out earlier or whatever it is. The days are shorter. You don't have to hire as many people. And that to me is still insane that hospital systems hire, consulting groups and pay $10 million, $50 million for them to audit their OR operations. And they just tell them, hey, you need so-and-so anesthesiologist to be on this side versus that's that's easy. It's like low hanging fruit that I think they should probably be doing as of yesterday.
Yeah. What were you going to say?
Well, I was going to say that, we have talked a lot about AI.
Mm-hmm.
I want to go to this point, and I don't mean to make a shameless plug for our other podcast, The Medical Brief, but every time on this podcast, Zain, we ask the guest, what other trends are you seeing for 2025? AI is the biggest trend by far that we're seeing in any, and then we've interviewed tens of people, 20s of people, 10, 20 physicians around the globe that say the same thing. AI is going to revolutionize how physicians and doctors do their job.
Take care of patients. Yep.
But I want to ask you, what is the other trend? If you're seeing a bigger trend in 2025 or a big trend in 2025, what is it in your eyes that you see could affect the way you do your job or could affect the medical industry other than AI?
Yeah. Huh.
Yeah, I think there's a couple. One, I think this year, for the first time and maybe since the pandemic, it's going to be a lot of people taking their own health into their own hands because the abundance of information that's out there. With the current, administration kind of poking holes in a lot of the what we thought was, baseline,
dogma.
Medical. Yeah, exactly. Well, we thought, whatever it was, that food coloring is safe for you, or these type of chemicals are good, these are bad. All these
let me warn you, don't mention the person's name who's saying those things because you get lots of hate for that. Even if you don't agree or disagree.
Even if you say his name for 2 seconds.
Exactly.
I don't know if
and it has nothing to do with that person at all.
You guys must have not seen my video that I made like a week ago or 2 weeks ago. It was about, can I say it or will it black
out?
Sure,
yeah, go ahead. I was making a joke.
I didn't know sometimes you can't say certain words on podcasts.
I'll say it for you guys. RFK.
Yes, we're talking about RFK.
So I made and I don't know, for reference, I don't know where you guys stand on the whole thing, but I made a video in RFK when he talked about, what was he talking about? Autism. He was trying to figure out the root causes, if it causes autism or not. And the video that I made essentially was that, hey, listen, it's probably, for reference, I have all my vaccines. My kids all have all the vaccines. I am a proponent. I think, generally speaking, vaccines are good for the world. They've changed the world. Right. But that being said, I also understand the fundamentals of business, and the incentive structure that they have for vaccines is that if it gets on the childhood schedule, that is like hundreds of billions of dollars of revenue. It's not just like a few, a small little amount of money. If you can get on
forever. Yeah.
And if you get on that, whatever that is, you pretty much guarantee that the government will subsidize your factories for life. So that you become like critical infrastructure or whatever it's called. And because of that, they need to have those vaccine, that plant functioning all the time. And so even if there's any hiccups or if there's some, loose business practices, a lot of things will be looked the other way. So the point I made in the video was essentially that, hey, I am 100% a believer of vaccines, but if someone's going to question it and talk and investigate whether or not all the regulatory rules are being followed, if there's not inflammatory materials in there or whatever the thought process is, and they're just going to unravel like layers of bureaucracy. Just if they're going to unravel it, I'm for it. Like, hey, we're going to turn everything upside down. Just turn it upside down. But I sympathize with the view on the other side too, which is essentially that, hey, how do you know it's going to be unbiased? And you don't. But the thing is, you don't really know that it was unbiased when it was put into place either. So It's kind of like a rock and a hard place when it comes to that topic. But I personally believe that it's a good idea to look into why is it that cereals are on the food print? Like why is it that high processed sugars are on or not high, but derivatives of that are on the food feeding our kids, or in the Oreos or Doritos? Why is it that this color is banned in Europe and not here? And I've been eating Doritos for like 20 years. And so like why are all these things why do people turn a blind eye to it and say, hey, just because a previous, lead of the HHS or administration said that it's good, then the new administration says it's not, they're obviously wrong. So for me, it's like, hey, just bring out the data, let people a lot smarter than me read over the studies, that they come out with and opine on it with an opinion that I could then extrapolate and use to talk to my my patients about. And so I'm for it. I'm 100% for it.
Yeah, and I agree with you. I think saying, hey, we should look at how these vaccines were created and what they're doing to our bodies, and if there's any link to anything else. I have no problem saying that. At the same time, you can also say, I still think you should get the measles vaccine, right? I mean, these are not two mutually exclusive things. So no, I laugh about the RFK thing because I have somebody, a troll on my social media who every day on every posts something about this guy loves RFK, blah, 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 when I never said anything besides RFK said you should get your measles vaccine. And I agree with that. So
number one was AI. Number two was patients taking matters into their own hands. And I guess I should ask you to clarify, what do you think that means? Does it mean concierge medicine? Does it mean, not visiting the doctor? I mean, what does that mean in terms of taking it into your own hands?
I think personally, education and empowerment of the patient is going to change. I think for the past, for our entire lifetimes, if you got sick or if you had something wrong with you or some chronic issue, you just defaulted to your physician and whatever my physician told me that I should take, whatever, zinc or something. And I'm going to take it every single day, twice a day, because he told me it's 100% right. And I think there was a veil of secrecy for hospitals, doctors, medical professionals that, hey, we just trust everything that they say because they know better. And I think now, especially like kind of leads with the AI and other changes in people's health. I think people are a lot of patients are taking their own health into their own hands, whether it's like we're learning that fasting, like skipping breakfast is actually good for you, even though for like 30 years we were told you have to have like a big breakfast. And now it's like all these studies are coming out that, hey, if you have periods of no food in your GI tract, that it's actually better for cognitive ability, better for your energy levels, better for weight loss or whatever it is. For a long time, physicians, I was told when I was in medical school that breakfast, you have to have your morning breakfast. Like that's like
6 meals a day, right? Six meals a day is the best way
was a bodybuilding thing. And working out, I, for the longest time, thought that after you work out, you have a 30-minute window that you have to consume protein in. And now there's been like 2 studies in the past like 6 months that basically say that that's baloney and you can eat it any time. So like they're just changing. And now that information is way more readily accessible. And I think after the pandemic, a lot more people in general just want better, healthier lives. They want better food alternatives. Like we were talking about the masa chips earlier. Like people want the ability to kind of choose to eat healthier stuff, do healthier stuff, like work out more or whatever it is. So I think this year is going to be the first year. And this will probably go into my next big topic, but I think along with the GLP-1s, I think it's going to really change the way people view their own health. Because I think in the past, when you were a certain weight or you were at a certain point where you were, COPD or hypertension or kidney disease or overweight, you're just like, okay, I'm done. Like I can't come back from this, so I might as well, if I'm in the mud, I might as well roll around a little bit more. But I think this year and going forward, a lot more patients and people in general are going to take their own health into their own hands.
I think it's generational too. I mean, we push a lot on generations, but like the baby boomers are like, "Ma, everybody else should do it for me. I'll let the doctor think for me." Blah blah blah. And then we're Gen X. I think you're a little bit younger. You're probably late or early millennial, right? But
yeah.
But being Gen X, we're like, we don't care. We're gonna do what we want. We'll figure it out, right? You used to leave us at home by ourselves all the time. I mean, I set my microwave on fire once, cooking food, like just home by myself, So. I think it's a generational thing too. We're much more like, all right, we're gonna have to figure this out on our own because nobody gave it to us like the boomers. So I would agree with that. The new drugs, so you're talking about GLP-1s, the new drug, there's some new drug out, right?
Yeah, I think it's called Retruotide. It's in phase 2. I think Lilly just announced the results. So Lilly makes Mounjaro, tirzepatide, and they came out with a pill version that actually acts on 3 receptors instead of 1 receptor, which was Epic, 2 is Mounjaro. And this one's 3, and it actually cuts 30% of your body weight within 9 months, which is insane. Like I think at some point it's too fast for your body to respond to. But the reason why I'm like, 30% in like 9 months, that's crazy. And
so it'll make you feel more ill faster, more rapidly, stronger.
The reason why it's cool though, I think, is once they figure out the pill, it's a silver bullet. You can spend a weekend out in Vegas, eat, drink, do whatever you want, and then come home on a Tuesday, take the pill for like 3 or 4 days, and lose the weight. Yeah, lose the weight and whatever you put on. And so that dynamic is going to really change how people enjoy themselves, but also how people lose weight and think about their weight loss.
So back to insurance companies. Are insurance companies going to start paying for this?
That's the goal. I mean, so two things. I think yesterday CVS agreed with Novo Nordisk to fulfill their cut their costs. Essentially, it's a race to the bottom now. So up till now, it was essentially like a luxury good, but now that Lilly ended up winning that war essentially for the past 2 years, and Mounjaro was proven to be better than Ozempic. So Ozempic was the first to market, so everybody knows it, but it has horrible side effects. You're nauseous and you're just tired and whatnot. Mounjaro does a little bit less of that, and so Lilly ended up becoming the favorite for a lot of physicians, Hollywood stars, whatever, as far as prescribing goes. And it was a bit cheaper, and it was made in the U.S. or I don't know if it was made in the U.S., but Novo.
It is, yeah. Lilly does most of their stuff onshore, so they make most of it. Some of it's in Mexico, but a lot of it's in the U.S.
So they were advantaged from that standpoint. So Novo was falling back. The market cap actually got cut in half in the past year. So they decided to start partnering and say, hey, and Lilly also had a direct-to-consumer option. So you could just go on their website and they would just, video call you with a physician, and then you just get the script written. And then all these other like Hims and Hers and Ro popped up, where essentially physicians would just prescribe it because there's very little downside to it unless you have certain issues, and you just need somebody to kind of screen for that. And so now Novo has started. Yeah, I was like,
should have been AI.
It will be AI for sure at some point. But Ozempic now, or Novo Nordisk, the maker of Ozempic, starting to make deals with insurers directly to cut the asking price, essentially. So this will probably reverberate back and forth between the two, and the cost of the injections will go down. I don't know about the pills. I think the pills will be the new luxury item that, hey, if you have a GLP-1 pill, and I've never even tried it, but if it was in pill form, I would probably try it too. I mean, I don't like shots, but hey, if it's a pill, why not? I'll try it a couple times.
Well, semaglutide comes as Rybelsus. It's not as effective, but semaglutide comes as Rybelsus. So, I mean, people get decent results with that. It's definitely not the 15-20% weight loss that you get with the injectables, but I think the last Rybelsus study was maybe like 7% weight loss. Still something,
Yeah.
So is there a final trend that you're seeing? I mean, that you want to mention in 2025 that you could foreshadow, that you could see happening by the end of the year? That would.
I think the biggest trend is going to be, you're going to see hospitals consolidate. I think. I think people tend to, and I'm going to make a video on this, Brian, if you want to partner with me on it. It's going to be essentially talking about the ramifications of the Affordable Care Act and how it screwed over physicians. Basically put 100%. In the context that physicians can't own hospitals. And then all the studies in the past, I think it was 20 years ago or 15 years ago, whenever it was passed, 10 years ago.
15, yeah, 2010 is 15 years ago.
All the studies have shown that in hospitals that are owned by physicians, cost is lower, turnover is faster, patient satisfaction is better. And at hospitals that are run by MBAs and business people, it costs more, you stay longer, you have worse results. And that doesn't really make the newsways. But as a result of that kind of setup, a lot of the critical access hospitals around the country are now going bankrupt because they don't have the referral flow. All the physicians that are good, fast, make a lot of money, or do a lot of procedures or whatever,
go to the cities,
go to the cities because that's the only place they can go. They can't own surgery centers in most states, and they can't own their own hospitals in most states unless they already had one from before. So all the talent pool is being pulled to the big academic centers, all the good physicians, good nurse practitioners, or whatever. If you want to make money and you want to have a life, you're going to go to those places. So all the critical care access hospitals are getting less effective care, less reimbursement, and now they're going under. And they're going to be absorbed by these giant hospital chains. And the hospitals have essentially figured out, as a result of Obamacare or the Affordable Care Act, that insurance is more profitable than the actual hospital itself. So if you can own all these little
insurance, vertical integration,
and then you can just you can see the patient in these smaller towns, and then just send them to your major centers, bill for it more, and then or whatever, Medicare or whatever insurance company they're billing from, or deny care because they are an insurance. So I think that's going to be a massive trend. I don't know if it'll happen this year specifically, or maybe in the next 2 years or 4 years, but I think a lot of hospitals are going to go under. A lot of hospitals run very thin margins as it is. I think it's like 2 or 4%. And so they're not going to be able to keep up with rising costs, the inflation stuff. All the tariffs are going to hit those small critical care access hospitals very intense. I mean, the cost of a syringe is going to go up 10-20%. They're all made in China, you know, all the saline bags come from Mexico, so or wherever else. So it's like the cost, they're going to go under. I mean, whether it's in the next 6 months, 8 months, year, I think that's going to be a big trend.
I'd make the argument that critical access hospitals get a lot of federal funding. So I think the critical access hospitals, the very small ones, 25 beds or less, are probably going to survive. What's going to happen is all the community hospitals, right? So if you're 26 beds to 150 beds, you're a community hospital. You're screwed, right? You don't get any federal funding. You probably don't do trauma, so you don't get federal funding from trauma. You don't get the critical access funding. I mean, those are probably going to be the ones. I mean, critical access may go under too, but I think in the next 6 months to a year, you're going to see a ton of that. Then the next question is private equity. What's going to happen with private equity? What are they going to do? I mean, I think, are they buying up hospitals? Because HCH
looks like it.
I mean, there's certain companies tried that, and it didn't work so well.
What's your take? I mean, I have a take that I think it's not. The gravy train is gone. The money that was free money for the Affordable Care Act and all that stuff for owning hospitals has gone under. I think RadNet or whatever, that big private equity group that bought all the radiologists, they just sold it to another company. I don't know which one they sold it to, but because then they lost. It was a $3 billion purchase, and they sold it for like $150 million. So it was like a 98% write off. And so I think that the gravy train for medicine is kind of gone. So I don't think they'll own physicians. Hospitals, maybe. I mean, I know there's a few of those, but my opinion is I think the model that Kaiser has or Intermountain Health has, those type of models will dominate regions. That's my opinion. I think it'll be like big conglomerates in every corner of the country, and at some point they'll all merge and become, you know, kind of like one giant college conference.
Yeah, maybe. I mean, so there was a rumor that the Catholic systems were all going to join, right? So Common Spirit was going to join with Ascension, was going to join with Trinity, was going to join with whatever, and become one big Catholic system. And I think they kind of floated that to the federal government. The federal government was like, no, that's not happening.
We don't like that much.
We don't like that at all. So
I'll chime in with another trend that I see happening in 2025. CLASP.
Hey, there we go.
Shameless plug, but it's not shameless. It's a great plug.
That was a great plug.
So
Zain, why don't you, because you've been affiliated with CLASP for a little bit longer. So obviously anesthesia is very hard to recruit right now, right? And so anything you can do to set yourself apart to recruit, particularly CRNAs, but anesthesiologists as well, is a big deal. It's expensive to get school paid for, right? School is expensive for CRNAs and for docs. So tell us a little bit about your interaction with CLASP, and then we'll share a little bit as well.
And what is it?
Yeah.
And what is CLASP?
Yeah, so it's super interesting. I mean, they reached out to me and they told me about they're a company out of Chicago mainly, but they have a lot of backing from Silicon Valley and, you know, tech startups and tech founders. And their founder is actually, you know, from that realm of tech startups. Their essential work, the way they work is they shift the dynamic of loan repayment. For the longest time, it was the government basically subsidized and then paid off or paid a lot of loans for a lot of physicians, for a lot of nurse practitioners, CRNAs, if you worked in underserved areas, or if you did certain, you know, met certain metrics, or paid, you know, 10% of your salary for 10 years or whatever it was. There's like 5 different options of this. But the government was essentially backstopping a lot of the graduate education. You know, this wasn't, I did not predict this, but, you know, when the new administration took over, Elon and all that stuff, they were kind of looking at cost cutting measures. And as of, I think, 2 days ago, they proposed an idea of getting rid of the majority of loan repayment programs in the federal government, but specifically for graduate loans. So medical students, medical residents, SRNAs, CRNAs, and you know, PhDs and that kind of stuff too, and lawyers and dentists. They're going to get rid of the payback option. So CLASP has a unique view on this, and I don't think they predicted that the market was going to shift this way either.
Serendipity, for sure.
Yeah, but timing is impeccable. So before, in the past, you know, just to take like a real world example, our parents or, their parents, when they worked for GM or Ford, there was no such thing as a 401k. They essentially had a pension program where the employer paid for, and then they figured out, whoever figured out that, hey, if we shift it to the 401k version, they'll save a lot of money for the companies, and the government will essentially, or whatever, it'll be a different model. And so now the 401k model is here. So in the past, and I think for the past 30, maybe 50, 40 years, a lot of the education has been backstopped by the government, and that has led to the cost of education like skyrocketing. So outpacing inflation, outpacing the cost of living, and outpacing the job that you're going to get when you come out.
Yep.
So when our parents went to college, they paid maybe $2,000 for a semester. I went to college, it was like $20,000. The kids going now, it's like $40,000 or $50,000 for undergrad. And the reason they can do that is because at 18, the government allows you to take out an insane amount of money,
$500,000 in student loans. Yeah.
And then all that money goes to those institutions, right? So that dynamic was unsustainable, and it was gonna collapse at some point. I didn't think it would be this fast, but it was gonna, eventually you can't support that many kids getting education with unlimited funds. And then if you come out as, I don't know, a dance major or whatever it is, you're not gonna be able to pay back $500,000.
Never.
Maybe over like 80 years of dancing or something, but it's impossible, right? So it was unsustainable. And so CLASP actually changes the dynamic where the employer, so like you said, Brian, it's very hard to recruit anesthesiologists, but medical professionals in general, because when you go to a new hospital, there's onboarding, there's background checks, there's meeting the team, there's all the shadowing, figuring out the workflows. And the estimate is, for an anesthesiologist, when you hire them, it's somewhere between $20,000 to $50,000 worth of training that you have to put in, time. Other people have to come to set up the banking, the payments, and the insurance stuff and all that stuff. And then if you turn over, so if somebody comes and leaves after 6 months, you're out, the hospital or the entity is out $20,000, $40,000. And so CLASP has actually flipped it on its head. So they have a loan repayment or employer-sponsored loan repayment program, which for the longest time, for anybody listening, it was like, hey, don't do that, because you're essentially signing your next 5 years away. And if you leave, you lose all of it. And so nobody would really, and I wouldn't do it either, sign when you get the offer. It's like, hey, you can get a signing bonus or we'll pay back your loans. But if you leave before your contract is up, you owe us X percentage, all of it back, whatever it is. And nobody did it. So CLASP has changed that dynamic with venture backing and I guess different ways that they do the banking or whatever it is. They have put into their contracts that, hey, if you sign with, I think they have something in New York and like Baylor Health, or I think it's Baylor and Northwestern. So if you sign with them and you work there for 6 months, they will pay back your loans for 6 months. And then if you decide, hey, it's not a good fit for me, I need to go somewhere else, you get to keep that money. Yeah, you get to keep the money. And so that is, and that's great on both sides, because the employer is showing you that, hey, I am in support of you coming here, and I'm not going to hold all these fine print in the contracts. Hey, I trust you to be an employee. And then on the back end, you're like, hey, this guy, or not this guy, but this employer is actually saying that, hey, it's no strings attached. So if I don't like it, I'm not beholden to being in this horrible job in the city that I don't like, or whatever it is, because I'm going to lose $80,000 in my payback. So it's a cool opportunity. So when I spoke with the founders, they're super nice, and I think, Brian, you spoke to them. They're super nice, super normal people. And I personally only work with companies like that. I try not to work with companies that are people that are, jerks or out to scam people. And these guys, Tess actually, and her team has a different view on it, and she's really out to empower healthcare providers. So that's kind of my back and forth. And I'm happy with the work that they're doing. And I think it's serendipity, like you said. I think that's going to be the future of signing contracts in the future. You're going to have, hey, I have $200,000 in loans. And I think right now she's got it up to like 90K, but I think in the future, it's going to be the whole thing.
Going to have to go up. Yeah.
Yeah. It'll be the whole thing, and it'll be cool. They're really far ahead of their time. And I think they will integrate very well into where the future is going for healthcare providers.
Yeah, I like it on both ends. I like it as a business owner and as an executive in an anesthesia company, because it helps us to recruit, right? If I can go to a CRNA in particular, because we have a lot of CRNAs in the company, and say, hey, listen, we'll pay back your student loans if you come sign with us. And not only that, you can start that repayment as soon as you sign the contract. So you might sign the contract in January, but not start until August, you can actually start repaying that loan. We'll start repaying that loan right away. And then, like you said, it's not like I'm giving you 200 grand to go pay your student loan or 90 grand to go pay your student loan. I'm paying whatever your student loan payments are for the next 6 months. And if you leave in 6 months, we say, hey, part ways. You're not going to have to give me that money back. And I'm also not going to go have to chase you for $80,000 or $90,000. So, but yeah, I agree with you. They seem like they are very above board. They seem like they're very much, I mean, it's a business. They want to make money, but they want to help the industry and they want to help people as well. So we're just in their early processes with them, but I'm excited to work with them.
Awesome.
Yeah.
Well, guys, we could talk for hours. I feel like we but how about we just plan to set another date?
Yeah, let's do it.
So we can have another conversation. We're only 5 hours away.
You're close
so I mean,
you're
close
now.
You got to make the drive. Well, now it's fine, but there's been hurricanes up here. I mean, we just had a tornado like 2 days ago. So once the weather gets back to normal, I'll definitely have to make a trip out there.
We'll have to do a podcast at Falling Water. Have you ever been to Falling Water?
I have not.
You got to go to Falling Water. It's one of my favorite spots. Frank Lloyd Wright home, just about 40 minutes outside of Pittsburgh.
Huh.
Beautiful plot of land. So
how far are you from like Lake Erie? Is that close?
Yeah, hour and a half.
Okay. All right.
Yeah.
Nice. Well, man, thank you so much for hopping on the call. I know you're a busy guy, and we always enjoy seeing your funny videos that you post. The funniest
anesthesiologist on ChatGPT.
Brian's coming for your title.
I love that. I love it.
I don't mind being second.
Well, we are brought to you by Butterfly Network, and appreciate everything CLASP is doing as well. And a shout out to them as we're both partnering with them. So, Dr. Zain Hassan, thanks for joining us.
I love it. See you guys soon.
All right. For Dr. Brian Schmutzler, I'm Vahid Sadrzadeh. We'll see you in the next one.